Hi, everyone. I'm Dr. Gary Glassman, but feel free to call me Gary, and I'll call you Carlos. I am thrilled to be here launching the very first episode of Dental Talk. As Chief Dental Officer of Dental Corp, I get to combine my passion for dentistry with my love for connecting with other professionals. As a practicing endodontist, when I'm not chairside or sitting in the boardroom, you might find me lecturing somewhere around the globe or mentoring the next generation of our future dentists. I'm very excited to take a deep dive into some fascinating discussions about the future of dental care in Canada. So let's get the conversation started. My first guest is Dr. Carlos Quiñonez, and he is a dental public health specialist and Vice Dean and Director of Dentistry at the Western University Schulich School of Medicine and Dentistry. He's a globally respected authority on the political economy of dentistry and is regularly called upon by public and private agencies to provide advice on issues of dental care policy. Welcome, Dr. Quiñonez.
Thank you, Gary, and of course, call me Carlos.
Okay, Carlos. I think one of the most polarizing discussions that we have today is the Canadian Dental Care Plan. So I thought we would discuss about that, and what I'd like to know is what was your first reaction when you heard about the CDCP?
So my first reaction was positive. As you know, I do research in areas around the political and economic history of dentistry and what kind of dental care system we have and what types of outcomes that leads for individuals and populations. So I was one among many who have been calling for a better balance in the financing of dental care, meaning public and private payment, as well as in the delivery of dental care, again, being both public and private delivery. So when it was announced, I tended to be positive about it, and I still remain positive about it. At the same time, it was not a surprise. You don't need to be a historian of dentistry to see where Canada has been moving in terms of dentistry, as well as where the globe has been moving in terms of dentistry. So while you couldn't predict it to a particular government or a particular era, you knew that we were headed towards a more, what I would call, a balanced approach to the financing and delivery of dental care in this country.
And you feel the overall objective of the CDCP is to provide access to those who otherwise wouldn't have access to proper dental care?
Well, the stated goal of the CDCP, as based on federal documentation, is that it's relieving a cost barrier to dental care, which of course improves access. But there's any number of reasons why access to dental care in Canada can be challenged. You can have a disability, for example, and have all the money in the world, but still have a challenge being able to access dental care. But cost is the major barrier, so that's what it's trying to alleviate. That's where we are.
So there's a lot of several other international models, the UK, Australia. How does the CDCP compare to the dental care systems in those countries?
So I don't want to necessarily concentrate on the UK or Australia, not because I don't know about them, but with respect to the UK, that's the sort of like the boogie man, the boogie woman, the boogie person, whatever that everybody points to, right? And they have some very, very serious challenges there, and they're playing out right now with respect to access, with respect to provider satisfaction, patient satisfaction, quality of care, all these things. Australia doesn't have these types of challenges. But again, not comparing to any one country, I will say that my study, and I'm not an expert in this, but I've taken some deep dives into international oral healthcare systems, points to the fact that there's a tremendous amount of variation, unlike in physician care or hospital care. Now, there's still variation there, of course, but how different countries have chosen what to do with dentistry is almost a mystery because it sits so separately from traditional policy discussions in healthcare. So what's my point? My point is that every given country does incredibly unique things. So to say that the CDCP somehow maps onto another oral healthcare system internationally is probably not the best way to look at it. The way I like to look at it is if we look at how much other governments internationally invest in dental care, we are a complete outlier. So if I can give you some numbers, out of every dental care dollar, Canada, pre-CDCP, invested about 4 to 6 cents publicly. That's what governments paid for, whether it was federal, provincial, or municipal. So all the public dollars added up to about 4 to 6 cents out of every dental care dollar. The highest in the world is Japan, where 75 cents out of every dental care dollar is financed by governments.
Interesting.
The OECD average, the Organization for Economic Cooperation and Development average, is about 33 cents. Just to give you a sense of how much of an outlier we are, the US spends 10 to 12 cents. So adding the CDCP will only shift us towards what is the mean or the average across the world. And there's a lot more detail in there, but I will say one more thing, which is general, but I think it applies, is that the CDCP moves us closer to a mixed system of both financing dental care, meaning who pays and how it's paid for, and delivering dental care, meaning how it's delivered and who delivers it. And that tends to be a public-private mix. So we are so, leaning into the private side, which has its benefits, of course, but it also has its drawbacks. And we're just sort of equilibrating again to what would be considered a more normal state of affairs internationally.
So with the public and private sort of model, one of the biggest concern I would imagine would be the quality of care that's being provided to these patients. What's your opinion on the quality of care for those that were going to be, private versus the public system?
Okay, so that is a very good question, and I think an opportunity to sort of, I don't want to say allay some fears, but give clarity as to what you might mean by quality of care. So if you look at the international health policy literature, quality of care may not mean what you think it means. An aspect of what you're pointing to, and correct me if I'm wrong, is, the quality. Is it good dentistry?
Right.
Is it technically done well? Is my margin closed, right?
Right. Is my root canal obturated to the apex?
Perfect. Exactly. Well, that's only one aspect of quality. If you look at quality of care points to safety. Quality of care points to access. Quality of care points to patient-centeredness. Quality of care points to equity. So quality of care is more than just what you're talking about. There's issues of efficiency, technical efficiency, which I think speaks to a little bit of what you're saying in a sense, but then there's allocative efficiency, which is, am I allocating resources in the right places? Should I be doing more root canals based on population needs? Or should I just be doing orthodontics because nobody has oral disease and that's where we can spend our money? Right. I know those are broad generalizations, but my point is that quality of care is a much broader term. And in that regard, the CDCP helps in some other areas, but could potentially be damaging in other areas. So let's stick to what you've asked about. In an environment where you're having to deal with many more patients, potentially you may not have as much time with any given patient, which most reasonable people would say could have a potential impact on quality. But that remains to be seen. There are systems all over the world that function with a more balanced public-private mix that deliver absolutely exceptional technical quality in dental care, and I can point to Germany as an example, right?
They have a public system as well.
They have a mixed system. The way they do stuff is quite interesting, and maybe we can talk about that later on, because there are different options than the ones that the federal government in our country has chosen. So again, I think it's a bit more complex to what people generally point to, because, for example, we could argue that the CDCP will reduce differences in oral health outcomes between income groups, meaning it will make things more equitable. From the point of view of that part of quality of care, that's kind of a home run. But there are implications, just like you say, for things like technical quality, if I could say.
Right. So, lousy fillings as opposed to taking the time and doing a better restoration, better margins, better obturation to the apices is sort of what I was referring to in quality of care. And you brought up a very interesting point. It's more than that. It's access. It's the ability to see these patients that wouldn't otherwise not have been able to be seen before because they just couldn't afford it.
Yeah. And by the way, these are not things that we don't talk about in Canada and Ontario, where we are today. We have Health Quality Ontario, which reviews the Ontario healthcare system among different axes of quality, right? One of them is what you say. Now, I do also want to say is that what you're proposing is a hypothesis. We don't know what that is. And this actually allows me to sort of tackle an assumption that many people make, is that we say that if it's private dentistry, it's high quality dentistry. That's not necessarily the case. Now, I will say, though, that if you look at international health systems, when you have the ability and the capacity to pay, you can pay for Rolls Royces. So you end up potentially paying for highly sophisticated technical dental care. So there is a relationship, but just because something is publicly paid for does not by definition mean that the quality is reduced. And again, I point to different countries like Germany to show that.
So you're an educator.
Yes.
You basically run the School of Dentistry at Schulich at
With a
University
lot
of
of
Western
other people.
Ontario.
With a lot of other people.
All right,
yeah.
you're the head man.
Sure.
You're the head person. So the future of education and professional development, education for the dentists that are going through the program and professional development for those that have graduated, they're taking continuing CE. How should dental schools, this will be a 2-point question,
Sure.
How should dental schools adapt their curriculum in light of the CDCP? Or should they adapt their curriculum?
So I would argue that dental schools have been adapting their curriculum to this reality for some time. Things like a focus on the social determinants of health, right? The recognition that having an oral healthcare system that fully depends on people's ability to pay may not always lead to the best outcomes in terms of equity, for example, or access. We're focusing on the commercial determinants of health. And by the way, the commercial aspect of the dental care market is a commercial determinant of health. Often people will point to Big Sugar as an example of the commercial determinant, but it's, again, more complex than that. We are now also talking about the political determinants of health. Why would we arrive at this? Well, we know internationally that minority governments lead to a tremendous amount of policy change because people have to make deals, right? So I think we've been adapting to this in a whole host of areas for some time. I think the issue for dental schools, and here I'm obviously speaking for my dental school, but the deans, we sit around the table and we talk. One of our biggest concerns is what will the CDCP do to our patient volumes? Because if you think about it, the CDCP completely removes the economic or financial incentive that people had to go to a dental school, right? When you were in grad school, where'd you go?
I went to Temple University in Philadelphia.
It probably applies the same there. When you had to learn how to do root canals at a graduate level, you were probably treating people that came to the dental school because it was reduced cost care.
Right, way more affordable for them.
And that applies to all dental schools in North America, let's just say. And by North America, I just mean the US and Canada. That financial incentive, to a large extent, will be disappearing incrementally over time with the phased introduction of the CDCP. We are very concerned about that as leaders in dental schools, because if we do not have patient volumes in order to appropriately train safe, competent, ethical practitioners, what might the future look like? And we have been pushing the federal government to help us navigate that potential future reality.
And what would be the solution to that, to provide the volume of patients for dental students to be able to graduate with all the experience that they need?
So my personal opinion here, I'm not talking for all the deans, but my own perspective, and I should probably not just point to the deans, I'm talking here about the Association of Canadian Faculties of Dentistry, the omnibus organization that deals with all of us. So I'm not talking for them, I'm speaking just for myself. I think the solution is to treat dental schools like dental hospitals, which is what they are, right? We want rerun a large healthcare environment like any hospital, surgery centers, whatever, right? You should be able to walk into a dental school and get care at no cost. We should be funded in that way because then that means that people could come to our dental school and receive services that might not be included in the basket of services for the CDCP, for example. I think that is a very simple, I don't want to sound arrogant here, but maybe elegant solution that allows us to just get rid of all the potential problems in one big swipe. I will also say, though, that that's more complicated because of federal-provincial relations. Just like healthcare, post-secondary education is a provincial responsibility. So it sounds simple enough, but of course, politics always plays its role.
Yeah, it makes sense. I mean, you have patients who are going to be on the CDC plan that didn't have access, but at the same time, only certain services will be covered. Not all services, depending on their level of income, is going to be covered 100%, and there will be balanced billing by the practitioner. So that may be incentive enough to steer patients to the dental schools because of that extra fee that they're going to have to incur.
I agree with you, and I hope the federal government hears our call, and we are getting support from national and provincial dental associations in that regard, which is we're very thankful for that. But we really need to do something because you're potentially gutting your labor supply, and that's quite worrisome.
So you're an expert on the economics of dentistry, and obviously the big focus of attention is the effect of oral health on general health. By having better access to care for oral health, general health hopefully will improve and will be less taxing on the health system in the future. What's your opinion on that?
Well, I want to clarify what I'm an expert in. I wouldn't want people to think that I'm an expert in the microeconomics of dentistry, meaning running a dental practice.
Okay.
That's not my expertise. But with that said, the nature of my expertise, I will say that there are strong arguments to be made that oral health or oral disease has causal implications for systemic health outcomes. Now, I'm not as convinced as many others might be on a whole host of conditions, but where there's incredibly good evidence, things like diabetes. And we've done research in this area. Or my research team has done work in this area where we've shown that if you're a diabetic and you're a diabetic with poor oral health versus a diabetic with good oral health, you are going to suffer far more from very serious outcomes like blindness, like amputations, like very serious health outcomes for a diabetic, that if you have good oral health, you can forego. You won't have those outcomes. Think about what the cost savings would be for the oral healthcare system. For the healthcare system more broadly. I will also say that that's a treatable effect too, meaning if you take a diabetic with poor oral health and you clean them up per se, you will get improvements in health outcomes. I mean, that's amazing. I'm not as convinced for cardiovascular disease and for other conditions, but overall, I would say that there is a strong economic argument for the importance of making sure oral health is taken care of in the context of systemic health outcomes. And those economic arguments aren't just about the connection to systemic health. What about employability? What about being able to function well in our society? I mean, the benefits are significant, and there's research being done in these areas as well. I mean, for example, we know that over your lifetime you will make more money if you have straighter and whiter teeth.
Right.
One understands what the pathways might be for that.
Sure.
Fluoridated areas. I know that's a controversial topic, but fluoridated areas. Interestingly, the signal is that as a woman, you will be more gainfully employed over your working lifetime. We've done research to show that if we clean your mouth up, there'll be less presenteeism, for example, with respect to oral morbidity, meaning you're not going to be showing up to work with toothaches. Well, no surprise. The value of oral health is clear. And I'll end with this, or two things. The actuarial scientists in the U.S. with insurers have known this for a while. There's products in the U.S. for people, for diabetics and people with heart disease, for example, where we'll give you a little bit of extra insurance so that you can get your periodontal needs met because they know actuarially that they're going to save on the medical side. Similarly, the World Economic Forum recently published a report, co-published by the American Dental Association, Henry Schein, and Colgate, that is making the case for the economic benefit of investing in oral health. While I may be a bit touchy on the science, I think at least actuarially and at least from a logical perspective, you can cash that check from my perspective.
What's interesting is in 2010, I helped the country of Jamaica build their first dental school.
Oh, really?
In Kingston, Jamaica, at the University of Technology, Health Sciences. And our first cohort we graduated was 2015.
Oh, wow.
And from then, every 22 dentists have graduated, and slowly they've been manning all these centers, these clinics that they've had, which were unmanned for decades. And my recent conversations with Dr. Irv McKenzie, who's the Chief Dental Officer of Jamaica, I'm very close with him. He's basically said that the incidence of diabetes has decreased significantly since the dental school started graduating. And now, when they graduate, they work for the government for a certain amount of years, and just providing oral health and education to the dentist and having missions across the country has decreased the incidence of diabetes, which I find very fascinating and part and parcel with what you discussed. With respect to the ethical considerations, and I think we've already touched on some of that. How can we balance the business interests with the ethos of healthcare, and are there any potential conflicts between the public health goals and the private practice realities?
Of course, there are conflicts, and I get a lot of heat online for talking about these issues. But
Sure.
You'd be a bit naive to think that there are not inherent conflicts of interest when you're trying to deliver healthcare in the context of business realities. And by the way, I completely respect those realities. I don't think they can go away. I also myself am not naive to realize that there are benefits to a private model of oral health care. So please do not take this as somehow saying that the only appropriate system is a public one, because that is far from the truth. In fact, that would lead to potentially some very negative outcomes for oral health care in general. But clearly there are implications. I was talking with a group yesterday. We were talking about this very thing. And I pointed to an article in an obscure legal journal, funnily enough, that talked about, and not about dentistry, but said the inherent tension between caring and selling, right? And in health economics has studied this in healthcare systems, not just oral healthcare, for 50, 60 years, and technically it's called supplier-induced demand, right? And I think that explains it enough.
Interesting term.
So this is well known. So I'm not sure why people think that there's somehow some professional moral controversy or are aghast by this. So laying that foundation, of course, and one of the things that we do in dental schools, for example, is we spend some time helping students understand how to navigate that tension, because you will live with it. We've done research, for example, that shows that dentists who are more business-minded will engage in more protocol radiology than prescription radiology, meaning, people will just get a certain number of radiographs in any given interval versus making those types of decisions based on risk, right? We've done research to show that if you are a dentist with a significant student loan, and the loans are significant today, you will be making more aggressive clinical decisions. If you have significant business loan, same. If you employ more dental hygienists, same. If you have more toys in your office, same. That's human nature. You are not the same person if you wake up with $1 million worth of debt versus no debt. But it's an understanding how to mitigate that tension. And I think it can be done, right? I have a lot of confidence in dentists, partly because I spend so much time with them, and I know that most of them wake up in the morning not thinking about how much more money they can make. They think about how can I help my patients.
Right, and that would be the ultimate goal, how to help patients.
Exactly.
My father always told me, put your head down, work hard, take care of the patients, the money will come.
Totally. I couldn't agree with that more. So again, I find it hard that people sort of buckle when I start quoting this research and when others do the same. But this is the reality of the types of policy issues that governments have to deal with as they think about how to deal with oral health care within broader healthcare policy.
So looking ahead, how do you see dental care in Canada evolving over the years, and what further policy changes might be necessary to truly achieve optimal oral health for all Canadians?
Okay. This is a great question, because I actually think that we are so confused from a policy perspective with respect to oral health care. And I think the gains for us are from a policy perspective. We can think about business afterwards, but I think that we as a profession and governments need to get clarity on what is essential or medically necessary oral health care, right? What should your tax dollars fund? And again, I'm making gross generalizations here, but they're just examples. Mm-hmm. Should they fund root canals or should they fund orthodontics? And by the way, there's a strong equity argument for funding orthodontics, so I don't want people to misinterpret that.
What's that equity argument?
Well, there's research that shows that if you take two children, one is a high socioeconomic status child and the other is a low socioeconomic status child, and you measure self-esteem, mm-hmm. that the high socioeconomic child self-esteem doesn't change rather dramatically between pre and post orthodontic care. But what you're doing to the low socioeconomic child is you're leveling them up so they end up looking similar from a self-esteem perspective mm-hmm. to the high socioeconomic status child. Well, one of the goals of public financing is to improve everybody's oral health. But the more important goal, based on a variety of things, which we can get into, is you're trying to reduce differences between social groups, right? Mm-hmm. You want to make people more upwardly mobile.
Right. Give them the opportunities.
You want to reduce differences in the experience of pain, right? Over a lifetime. So that's my point. We have to rationalize. Why would we want more public funding in dental care? We have to rationalize what services should be in that oral health care basket. And by the way, if you thought anything I said before was controversial, asking dentists and governments to think about this issue, the level of moral controversies are significant. And governments deal with this all the time. That's why every once in a while you'll read in the newspaper, or poor little child can't get access to, a drug that costs $50,000 a month that's going to save them from the point of view of cancer, right? It's called the resource allocation ethics, right? Hard decisions need to be made about mm-hmm. what to give and to who, right? So I think I would have liked that question answered prior to the CDCP, because I think our policy trajectory could have potentially been cleaner, mm-hmm. right? And not so controversial, because we could all get on the same page as to, okay, what are we trying to achieve here? So that's one example.
Okay.
I think the other major thing that we need to think about is how to deal with this balance between public and private. And by this, I mean, how do we understand oral health care within broader healthcare policy? Because, one, we live in such a private system that we have our own goals that have become highly commercialized. And healthcare more broadly hasn't tended to work that way. So oral healthcare and healthcare, they sometimes don't fit, even though, of course, oral healthcare is healthcare. Mm-hmm. Of course, oral health is health. So what I'm seeing is a conflation of public and private spaces or universes colliding, and there's stuff flying off in every direction. So I think those are the policy wins that we can get once the temperature is down and we can sort of think more rationally about what is happening here.
Interesting conversation. Okay. Well, thanks for coming on to Dental Talk and being our inaugural interview, and really respect that. And thanks again.
Okay, thank you, Gary. Appreciate it.
Nice to see you, Carlos.